All right, everyone, welcome. My name is Eric Moody. I'm the Director of Research and Evaluation at the Wyoming Institute for Disabilities at the University of Wyoming, our UCEDD there, and also the Treasurer for the Collaborative on Faith and Disability. It is my pleasure to introduce Trace Haythorn, who's our speaker today. But before getting started, I wanted to make a few announcements on the Collaborative on Faith and Disability. Just to remind people that this is an ongoing collaborative housed within the Association of University Centers on Disabilities, UCEDD, and we have a SIG that we run every year at our conference, but we also have many other activities, including this webinar series and also the Summer Institute on Theology and Disability that Bill runs. So look for additional webinars as we go on, and here's a list of our partners. And so if you're interested in becoming a member, please let me know and we can get that set up as well. And a few important notes. One, that this will be a recorded webinar and that it will be made available as soon as we can on our website, faithanddisability.org. We'll also include several links if they're included in the webinar today. We're going to be using the Zoom platform today, and so you can add questions in the chat box, and as a moderator, I'll be monitoring that, and we can have time for questions at the end. I'll read the questions and or call in if you want to speak. And let's see, and there'll be additional information at the end about upcoming webinars. So with that, I want to again introduce Trace Haythorn. Dr. Haythorn is the Executive Director of the Association for Clinical Pastoral Education in Atlanta, Georgia. He's been the Executive Director there since 2013, and before that, he was at the Fraser Center and also the Fund for Theological Education and Hastings College. He received multiple degrees, many of them in nonprofit executive education and management from the Harvard Business School, Stanford's nonprofit executive education program. He got his PhD in the Cultural Foundations of Education from Syracuse University and his Master's of Divinity at Princeton Theological Seminary. So he's going to be talking with us today about tending to the spiritual needs of people with disabilities. And with that, Trace, I'll hand it over to you.
Great, thanks, Eric, and it's a privilege to be with you all today. Advance, please. So here's the outline of what we'll be talking about. I want to start with just a brief history of people with disabilities in the U.S. and to look particularly at the role of faith communities in this history. And then to talk a little bit about what the spiritual needs of people with intellectual and developmental disabilities are. I'd love to think about some inclusive faith communities while we're doing that. And then talk about assessing spiritual distress and needs and thinking particularly what we can learn from palliative care. There are some current initiatives in palliative care, particularly some national guidelines that have recently been released that I think are really helpful and show the kind of thoughtful and deliberative approach that can be taken in addressing spiritual care and the needs of patients. And that there's a good deal there that we can actually bring back into the IMDD community. I should say, though, before I dive into this, that while I'm grateful to Eric for all of those pieces that are a part of my bio, I really come to this as a dad. I have a daughter, Martha, who's 19, who has Down syndrome, and I actually finished my PhD, a part of which was at Syracuse, well, it was at Syracuse University in a field where I dealt with a lot of students looking at disability studies. And then Martha was born 13 months later. So it's one of those situations where I thought I knew something about this subject, and then Martha came into my life, and I feel like a novice ever since. So I offer that as a caveat as we dive into the conversation today. Advance, please.
Trace, before you go on, would you moving the mic just a little closer? We're having a slightly hard time.
Yeah, happy to do that. Thanks.
That's great. Thank you.
Yeah, so I'd like to start by looking back to 1817. That was the year that the first school for the deaf was established. Actually, it was established in Hartford, Connecticut, the American School for the Deaf. It was the first disability-related school in the Western Hemisphere. And when you think about it, that's only 200 years ago. It's not that long ago. So the attention and the awareness of this within the US is only beginning to emerge at that point. But it doesn't take long for something called, which was coined in 1975, the ugly laws, to take effect in 1867. Basically, those laws tried to deal with the problem of panhandling on the streets by those with disabilities. And mostly at the municipal level, so city governments were passing legislation that prevented people from panhandling if they had characteristics that were off-putting to others. Here's some language that was specifically from a Chicago municipal statute: that anyone who is diseased, maimed, mutilated, or in any way deformed so as to be unsightly or a disgusting object. It's just a painful characterization of where we've come from to be thinking about that kind of language related to this population. As we move past the Civil War and begin to head in towards World War I, institutionalization then became a sign of progress, where I would characterize, mostly out of an attempt to be kind, people tried to create institutions as places where folks could receive a kind of care that they could not receive in the public. So some of it was simply trying to remove people off of our streets, again, and move them into these institutional settings. Some of it became an experimental warehouse for the development of eugenics. And probably one of the most painful developments within the eugenics movement was the advent of eugenics connecting with theology. Christine Rosen has written a powerful book on preaching eugenics that looks at the role of the Protestant church in particular around how people with disabilities were really not in line with God's will, that God did not want this, and that it was our call as human beings to try to make the race more beautiful, if you will. Let's move forward to the 1950s, and we begin to finally see the birth of advocacy organizations. The ARC was one of the first that was established. And interestingly, in 1954, Brown versus Board of Education was not around disability, and yet there were important implications that began to emerge related to it. Okay, advance, please. In the 1960s, probably one of the most beautiful moments, if you will, was the birth of the Special Olympics, largely in response to the birth of Rose Kennedy. The Kennedy Centers became very important centers for research and support. And I think the 60s also were marked by the work of Jean Vanier and L'Arche around the world, that the movement of the Kennedys and of Vanier really helped move people out of the shadows and began to claim disability as a part of the human condition rather than as something that needed to be shuttered away. In the 1970s, we see the emergence of legislation within the United States. In 71, Mills versus Board of Education of the District of Columbia gave the first publicly funded education for people with disabilities. In 1974, the repeal of the last ugly law, that one I read from Chicago, finally took place, and really there were some residual elements of that all the way until 1975, until the Development and Disabled Assistance Act, Bill of Rights, was passed during that year. That was also the same year that the Education for All Handicapped Children Act was passed. As I'm sure many are aware, 1990, the Americans with Disabilities Act passed, and then the Individuals with Disabilities Education Act passed in 1990, to be reauthorized in 97 and 2004. Advance, please. So these are all important and critical acts, but I think what's noteworthy is the absence of any coordinated action by faith communities during this time. Now, to be clear, there are plenty of individual efforts. For example, the American School for the Deaf was founded by a Protestant pastor. But as I noted, Christine Rosen's documentation on sermons that promoted eugenics gives a scary sense of just how faith communities were really playing on both sides of this scene. For more on faith communities and their roles, take a look at Eric Carter's lecture at Baylor, and there's a link there in the slides that will be available when this is done. Any attention to the spiritual needs of people with intellectual and developmental disabilities has really been left to the initiatives of things like the L'Arche community, the work of Jean Bonnier and those communities that are around the world. But they still have a long way to go. So how do we change this, and how do we begin to make history in light of these circumstances? Advance, please. So since the 1870s, there have literally been hundreds of research studies on spirituality. There are a variety of contexts and subjects. Koenig's study in 2012 takes a look at these and gives an overview for an example of some of the contexts: acute care settings, elder care, and mental health. Some of the subjects that have taken place are coping with adversity, positive emotion, and depression. And yet, very little around spiritual care and disability has been studied and documented. So I thought it'd be helpful if we took a look at one area where there has been really good documentation, a good study, and some understanding that can help us think about how we might engage this more deeply with people with disabilities. Advance, please. So this area is palliative care. Basically, palliative care, which can be beneficial at any stage of illness, is an interdisciplinary care delivery system designed to anticipate, prevent, and manage physical, psychological, social, and spiritual suffering, that highlight is mine, to optimize the quality of life for patients, their families, and caregivers. Palliative care can be delivered in any care setting through the collaboration of many types of care providers. And through early integration into the care plan of seriously ill people, palliative care improves the quality of life for both the patient and the family. Note that when many people hear palliative care, they immediately think of hospice, but hospice is just one specialized form of palliative care. Palliative care is so much more than that. It is really a comprehensive approach to those different areas that we mentioned above: the physical, psychological, social, and spiritual suffering, to try to improve quality of life. Advance, please. So what was the concern for palliative care in looking at spirituality? Spiritual care is seen as important by patients and practitioners. There was a survey of 339 oncology clinicians, and it found that 74% of nurses and 60% of physicians desire to provide spiritual care when caring for patients with a serious illness. This actually surprised the researchers. They actually thought when they conducted this study that they would find that number to be much lower, that the spiritual care dimensions would not be their primary concern. The most frequently endorsed barriers of providing spiritual care include lack of time, which is 72%. Think of all the things that physicians are dealing with, nurses are dealing with. To actually turn and take a moment to pay attention to this has really been a challenge. Inadequate training, 61% don't feel like they know how to intervene in these settings. A lack of privacy. Most often when these folks are visiting with patients, they're in a room where plenty of other people are there, and it's hard to have these kinds of conversations when you've got an audience. And that spiritual care is better offered by others. So many of the folks who were included in the survey really felt like that just wasn't their job and that someone else should be taking care of that, or that they simply felt inadequate to the task so that others should take care of it in that circumstance. Inadequate training was identified as the strongest predictor of the lack of spiritual care provision to patients. When Tracy Balboni and her colleagues were looking at this, they were surprised and wondered what would adequate training begin to look like. An integrated structure for spiritual care, multidisciplinary teams, inclusive of chaplaincy, may also influence spiritual care delivery. So when Steinhauser and their team began to look, they noticed that most often when spiritual care was delivered well, the whole team expressed an appreciation for that role within the work. Advance, please. So within this, there are 8 primary domains related to palliative care. And this comes directly from the Clinical Practice Guidelines for Quality Palliative Care. This is a document that was just released in 2018. It is some of the most up-to-date guidance that's available within palliative care, and it's put together by the National Coalition on Palliative Care and Hospice. These 8 areas include the structure and process of care, the physical aspects, social and psychiatric aspects, social, cultural, and patient's needs for near end of life, and the ethical and legal aspects. The 5th domain within those social and cultural areas, in between the social and cultural areas, is the spiritual, religious, and existential aspects of care. The spiritual, religious, and existential aspects of care are described, including the importance of screening for unmet needs. What they're really looking for within these areas are those domains where people are asking questions of ultimate meaning and purpose. What are the things that, when they are feeling at their worst, when they're in a place of acute suffering, what are the kinds of things and the kinds of theological constructions they might have? And it may not be theological. It may simply be a very personal understanding of meaning and purpose. How do we attend to those in ways that provide for the greatest quality of life? Advance, please. So these are the guidelines that they developed for addressing those spiritual needs. And this is where I think there is a lot of instructional opportunity to bring this into the world of intellectual and developmental disabilities. Spirituality is recognized as a fundamental aspect of compassionate, patient, and family-centered palliative care. The recognition that spirituality is right there in the heart of all of this harkens back to some religious education theorists like Elizabeth Caldwell that think about all of those family meals where spirituality is formed, and the appreciation for how it is constructed happens within the home and hearth. Spirituality is a dynamic and intrinsic aspect of humanity through which individuals seek meaning, purpose, and transcendence, and experience relationship to self, family, others, community, society, and the significant or sacred. That language of significant or sacred is really important, especially as we begin to recognize the diversity of religious perspectives within all of our communities today, and noting that the fastest rising group of religious folk are actually those who identify as spiritual but not religious, what the Pew Research folks call the nuns, N-O-N-E-S, as opposed to N-U-N-S. Spirituality is expressed through beliefs, values, traditions, and practices. And palliative care interdisciplinary teams serve each patient and family in a manner that respects their spiritual beliefs and practices. This has been a really important claim and commitment within palliative care, especially when there are differences between the physician, the medical care team, and the patient and their family. It's even more interesting when the patient and their family have very different beliefs. Often the medical care team's job is to help advocate for the patient's spiritual beliefs, even if it may not be what's meaningful to the family. Finally, teams are also respectful when patients and families decline to discuss their beliefs or accept spiritual support. So just because you're offering doesn't mean that there's necessarily going to be an openness to the conversation. The medical care team, the chaplain, all recognize that this may be something that the family is going to keep to themselves. That doesn't mean that you ignore it. It simply means that you continue to be respectful and try to listen for cues of how you can be most supportive within that setting. Advance, please. So, guidelines for assessing spiritual need include the following. The first is what we call a global guideline within the overall guidelines. Patient and family spiritual beliefs and practices are assessed and respected. Palliative care professionals acknowledge their own spirituality as a part of their professional role and are provided with education and support to address each patient's and family's spirituality. Again, this gets to the particularity of much of the same thing that we would do in any kind of medical situation. You're looking at what the individual profile is, what the individual needs are. So let's make sure that we're paying attention to that in a way that addresses those spiritual needs too. It is very easy for a medical team to come in and begin to try to address this, but do it from making assumptions from their own religious system rather than really listening and asking the patient good questions. This comes through screening and assessment, Guideline 5.2. The spiritual assessment process has three distinct components: spiritual screening, spiritual history, and a full spiritual assessment. The spiritual screening is conducted with every patient and family to identify spiritual needs and/or distress. Sometimes this happens as early as admissions within some of these programs. Other times it happens when a physician begins to do an inventory, or a nurse practitioner or a nurse as they begin to look at what are the particular needs and concerns of a patient and family. The history and assessment identify the spiritual background, preferences, and related beliefs, values, rituals, practices of the patient and family. So within this piece, the move is actually more from a general spiritual assessment to something that might be a little more skilled or particular. Often this is the place where the chaplain steps in and begins to really help develop the profile, the spiritual profile for the rest of the team. Symptoms such as spiritual distress and spiritual strengths and resources are identified and documented. The spiritual distress piece is particularly important within palliative care because it can have, addressing those needs can have an important impact on pain management, on overall psychological and emotional stress, and on how the overall family system continues to function. Advance, please. Guideline 5.3 looks at treatment. So the interdisciplinary team, that's the IDT, addresses the spiritual needs of the patient and family. How are we going to do this? How are we going to make sure that these things are attended to? And then 5.4 for the ongoing care. The patient and family spiritual care needs can change as the goal of care changes or patients move across settings of care. So for example, there may be particular things, interventions, as we would call them, that a patient may want in the early stages of their care that they may no longer want later on. On the other hand, that may be exactly the opposite. Thinking of a patient that I worked with many years ago who only when they were in their dying days did they ever want scripture read with them. And they would ask me to come and simply sit and read some of their favorite Psalms with them as they were in their final days. Advance, please. So the clinical and operational implications are listed here. First, spiritual care is an essential component of quality palliative care. To have that kind of a commitment right up front from the palliative care world is, I think, another place where the intellectual and developmental disabilities community can really pay attention and identify how we move this to a place that says this is as important as these many other dimensions that we attend to. Spiritual care services, including screening, history, and assessment, are performed on admission and regularly thereafter. Interventions using professional standards of practice are part of the basic provision of quality care available to all palliative care patients. What this means is not that everything we're doing all the time has a kind of religiosity about it. That's a characterization, a trivialization of what this all is. Rather, that we recognize in the same way that we're paying attention to social, emotional, physical needs, we're also paying attention to those spiritual needs. The operational level and the operational implications. Specialist level palliative care programs include salaried professional chaplains and related programmatic expenses. Clinicians serving seriously ill populations may develop affiliation agreements with spiritual care departments at health systems, hospitals, or hospice programs that can provide timely access to professional chaplain services. One of the pieces of this that's been very important is a recognition that chaplains are the spiritual care specialists, while everyone else within the palliative care system are the spiritual care generalists. So as we think about that within the intellectual and developmental disability community, who could we identify as the specialists within those settings? And then who else can be generalists within those settings, and how do they work in this same sense of an interdisciplinary team? Even when these resources are available, partnerships with faith community leaders are encouraged and nurtured. The interdisciplinary team has policies and procedures regarding spiritual care consultation and processes for referrals. Advance, please. So the essential skills needed by all palliative care professionals. This is the generalist skills. The process and tools needed to conduct a spiritual screening and assessment for spiritual distress and spiritual needs can be learned by all clinicians. In addition, Clinicians can learn to identify and utilize resources available on the team within the patient and family or in the community care setting to ensure that spiritual needs are promptly addressed. The key research evidence supporting this comes through a systematic review addressed by the following key question. This is key question number 5 that was a part of this assessment. What is the effect of a spiritual assessment and/or intervention on patient and family caregiver spiritual and emotional well-being? Within this, 11 systematic reviews were identified pertaining to this key question. There's an evidence table and systematic review available within the National Quality Guidelines, the reference that I made earlier, and I encourage you to take a look at these as you begin to see what are these different elements that are really key in terms of the research evidence supporting this. Advance, please. So what are some basic assessment models? Now, I offer you 2 here. Both of them are fairly widely used by chaplains in a variety of different settings. The first is from Christina Polhowski and her team at the George Washington Institute of Spirituality and Health. Its nickname is GWISH. It's called FICA, and FICA is simply an acronym for faith. Are you a religious person? Are you religious or a person of faith? I is influence and importance. How important is faith to you? C is communal expression. What form or frame does your faith take publicly, if any? And A is assistance. How can we help? Part of the GWISH team's goal was to have something that was as simple as possible, but also really took the faith of a person seriously. And so this FICA tool is a very basic assessment model to get a sense of where a patient might be. George Fischette and his team at Rush University Hospital have something called the 7x7 assessment tool. The first is looking at holistic assessments: biological, psychological, family systems, psychosocial, ethnic, racial, and cultural, social issues, and a spiritual dimension. Those 7 areas are on one panel, and then across the other panel are the spiritual assessment pieces. So looking at belief and meaning, vocation and obligations, experience and emotion, courage and growth, ritual and practice, community, authority, and guidance. Now you can see the contrast between these 2 different assessment models. The first one is most likely the one that you would expect used by the generalists, where the specialists are going to be ones more likely to use the Fischette 7x7 model. Advance, please. So what are some barriers to addressing spiritual needs? These have been found in a variety of different research pieces, but it also shows up again in the palliative care guidelines. The first is just a personal or professional ambiguity, anxiety, or discomfort with the whole notion of spirituality and religion. The second is a negative personal or professional history. I'm thinking in particular of one physician that I worked with who, when I was serving as a chaplain, the only time that he wanted me to come around is after a patient had died. His understanding of my role was only to take care of a family after a patient had died, and he left the room at that point, as opposed to being a part of a team that was looking at the overall comprehensive care of both patient and family throughout hospitalization. Oppositional beliefs. It is not unusual to find people in a clinical setting who would simply have a very oppositional belief to the whole idea of faith or religion. So looking at that as being a barrier to any kind of assessment or inclusion within a team also makes it important for the team to bear the responsibility of this, not any single individual. Explicit organizational prohibitions. So there are institutions that simply will not allow a discussion around faith or spirituality. Recently, we had a case from one state where the state was actually looking at removing chaplains from all institutions that were state or federally funded out of a concern for the separation of church and state. There are plenty of court cases that have taken place that actually support attending to the spiritual needs. And when you think about how many military chaplains there are, you begin to see that there's some pretty clear support for this kind of spiritual care that is happening within government-funded entities. Concern for undue influence on a person with an intellectual or developmental disability. So the The concern here is how easily someone might be manipulated, and this is very similar with what takes place within palliative care because of how vulnerable somebody might be because of um, medications that they might be on, because of vulnerabilities related to pain, often some of the grieving issues related to bargaining with God. Someone can be in a very vulnerable situation. And so knowing that you have both good, well-trained generalists as well as well-trained specialists in spiritual care is an important part of this dimension. And then my favorite one is the last category, the fear of woo-woo. Simply an anxiety around those things that are spiritual because of what that might mean, and people's concerns that these are just not things that make any sense, especially when you're dealing with so much that is physical. How then can we begin to address this kind of spooky area that some might describe it as such? Advance, please. So what can those working with intellectual and developmental disabilities learn from palliative care? Well, the first is just this notion of what it means to assess spiritual needs. People with intellectual and developmental disabilities have the same needs as everyone else, and they are just as diverse in the experience and the expression. I'm thinking of a recent gathering where I was with folks from large communities from around the United States, and the different ways that people express their faith within that setting. And it's still a challenge within some large communities that still have a deeply Catholic heritage. How then do you make room for an individual living in community who is from a Muslim faith, or who is Jewish, or in this particular context, someone who is Buddhist? Modification. Just like all other forms of communication, there needs to be some modification and a strategy for those modifications. For thinking and talking and living with spiritual needs of people with developmental disabilities. One of the clear keys is one must be clear and grounded in their own perspective in order to be present to the spiritual needs of another person. One of the great concerns is not only the kind of manipulation taking advantage of someone who's vulnerable, but also proselytization, trying to convert somebody within a vulnerable space. In many settings, people with intellectual and developmental disabilities are going to be particularly susceptible to that. And people will bring a sense that that's what they're supposed to do, is to convert them to their way of thinking. Professional spiritual caregivers know that that's not the purpose of this. It is to help people discern their own sense of meaning and purpose and help them be grounded deeply within that. If you know your own perspective and are comfortable within that, you are far more available to the person who might be in a different place. Thinking about what the core institutional strategy might be for a particular organization. For example, what are the integration of similar guidelines and principles into state, federal, and independent agency guidelines? How do we look at what the strategies are for a place while it's still trying to pay attention to some of those state, federal guidelines, or if there's an agency guideline that's available there too? One needs to be careful that they don't cross those lines, and yet, as I noted before, there's plenty of examples of how spirituality is integrated to a variety of settings that people might think of as being particularly secular. And then thinking about the core individual strategy. I actually borrow from Jean Vanier in this. We human beings are all fundamentally the same. We all belong to a common broken humanity. We all have wounded, vulnerable hearts. Each of us needs to feel appreciated and understood. We all need help. I think that kind of commitment speaks to the heart of spiritual care with people with intellectual and developmental disabilities. Advance, please. So that's most of the content that I wanted to present today. There is a great deal more within the national quality guidelines, and I encourage you to take a look at those, but we wanted to leave time for questions and answers today. And so, Eric, I turn it back to you.
Thanks, Trace. That was a great presentation. So to everybody on the webinar, please feel free to post any questions that you have in the question and answer box. Those will pop up to me and I'll read them out. While you're taking some time to do that, Trace, I had a question. You mentioned that there's a hospital system that is, and I might have missed this, they've either planned to or have taken out all of their chaplains if the institution is state or federally funded. Is that right?
So there was a system in a state that raised a concern about that, and that they are not going to do that now, largely through our intervention. But the concern was because it was a state-funded place that they could not provide spiritual care, and there's simply far too much case support for attending to the provision of spiritual care that's no longer going to happen.
Okay. I guess part of that question is, do you see that as a growing threat across the nation, or is this kind of a one-off situation?
We wondered if it might be a precursor to some things as we were looking at how we provide spiritual care within that state. And we now think it may be related to a particular assistant district attorney and not a trend.
Got it. Okay. And we're getting some questions in, so I'll read these out. One question is, has spirituality ever been addressed in assessments or other services related to Martha?
So yes, and in fact, my family and I, we are active in a local Presbyterian congregation, and Martha has now been ordained in one of our lay offices. We have two different kinds of lay offices, both deacons and elders. Deacons are the caregiving spaces, and Martha is an active deacon. In fact, the deacons love it when she comes to meetings because she is the one who quickly volunteers to both open and close the meetings with prayer, which I think is hilarious that so many others feel so uncomfortable with that, and she feels totally comfortable and at ease being the one that would provide that. But some of that came around with, what are the ways that Martha can fully participate in the life of our faith community? And that was one of the ways that began to surface very quickly, is that she loves to be in a caregiver role, and she is received very well by members of our congregation in that.
Great. Let's see, we've got another one from Vanderbilt, it looks like. What might spiritual assessment look like for individuals who have complex communication needs or are nonverbal? Is there any good guidance there?
Yeah, so obviously a good deal of this biases and privileges verbal communication. And some of the ways that I think the FICA tool in particular can be really helpful is simply exploring what are the other ways that we've learned to communicate with this individual. So if someone is using a touch board, for example, I'm thinking of a member of our local community, my neighborhood, who is in her 70s. She has cerebral palsy and is only able to speak through a touch board. She actually participates in the choir in her local church, and is an active participant in a variety of things within her congregation. The ways that they have learned to be with her have largely been around coming to deepen their own patience with the amount of time that it takes to communicate well with her. What are the tools that you're currently using to communicate in other ways, and how can you use those tools to address those kind of FICA assessments with folks? Yeah, it's not a terribly difficult augmentation or adaptation.
Great. We've got another question from Aman. I live in New York City and work in Midtown. I'm Christian, so I don't see an issue with thinking prayer provides healing, but how do I have conversations with folks who think it will? I'm an amputee, and I can't tell you how many people have come up to me offering me a prayer as if it will make my legs grow back. Any suggestions would be helpful.
Yeah. My father was an amputee as well, and we had a neighbor several years ago. We lived on the west side of Nashville, and we had a neighbor that regularly told us how she was praying that our daughter would be healed, and we weren't quite sure what that meant. I think part of where we have grown in our conversations and the teaching we do through ACPE is to really encourage people, when somebody offers that sort of a prayer, to have a pretty clear understanding of where you are with what that means for you, knowing that they mean something very different. So in the case of my neighbor, we always simply thanked her and wished her well, and received that prayer the way that we needed to receive it, rather than receiving that prayer the way that she needed us to receive it. That is, I think, an important part of the disability conversation, so that particularly in those complex communication settings, um, to think you know what someone else's experience is, even when you can be very articulate, is simply not possible. We can never fully know another's experience. So if we can acknowledge that from the onset, making room for each of us to experience whatever kind of spiritual awareness, spiritual sensibilities we have. I really like that language of what is your sense of the significant and the sacred. Um, I know that part of the reason people want to offer those kinds of prayers of healing comes out of what I would hope is a genuine and kind place in their hearts. If I can stay there, then I'm more likely to be a kind recipient of that moment.
Great. Bill actually had a follow-up question to his previous one. He said the question really was, has a service provider or an educational assessment, for example, an IEP, ever asked about Martha's spiritual interests and opportunities? That is, anyone ever asked her or you something like FICA?
So yes, and we actually did that very intentionally. We had a new youth minister come into our congregation, and Martha was a part of the youth group. And so we brought in sort of our own modified FICA to help the youth minister engage with Martha in a way that was paying attention to those dimensions. So we actually did this in a very structured kind of way. Some of that is because of who my spouse and I are, obviously, but we would love to see that tool used more readily within those kinds of contexts. I think in youth ministry it's important, but in any congregation, rather than people assuming they know what they need, and sort of a negative spin on that is often we simply defer to the parents to respond on behalf of the person with a disability, and I don't think that's helpful. I think people have their own ways of expressing and speaking for themselves.
Yeah. I've got a question from Joan here. I really appreciate the vision of specialists and generalists and the assessment of folks in L'Arche. I think I said that correctly. I can see the value of developing a tool for generalists as they welcome both new core members, people living with IDD, and assistants or core members who come often these days as spiritual but not as religious. Is there a tool in palliative care that we might adapt for our setting?
Yeah, I actually, again, I think I would refer to the FICA tool. There are a couple of others that are available out there, and I'll see when we post the slides if I can put a couple more of those resources up there. I'm thinking, I've worked closely with L'Arche Atlanta over the last several years, and I think the FICA tool is a great way both for incoming assistants as well as core members to be thinking about and expressing who they are and what they believe. I think it's really helpful, especially if an assistant finds themselves accompanying a core member to a worship setting, to have that kind of clarity between the two of them as to what that experience is going to be about.
Miriam, I think, had a comment to follow up on Aman's comment about his legs growing back, that I often tell folks I will pray for them too. So I'm not seen as the only one needing prayer.
Yeah, that's great.
Yeah. And let's see, then Mary Jo says, I'm the inclusion ministry coordinator for a Presbyterian church, and I am also a person with a disability. I have developed different programs for persons with disabilities that are to include all, disabled and non-disabled. Unfortunately, the non-disabled members still are reluctant to attend. How do I help unite these two groups?
Yeah, that's great. I think the strategies that I find most helpful is actually embedding people with disabilities in existing programs. So I'm thinking, for example, like with our daughter with youth ministry, rather than having special programs for her or things that that might have been an alongside program, if you will. She's participating fully with the youth, and there are two other youth that are active in the church as well that have developmental disabilities. So we as a family worked with the leadership to try to develop sort of our church's version of an IEP. It is not as formal, it is not as structured, and it certainly doesn't have all the legal mumbo jumbo in it. But it has provided all the different members of the team and the youth in the youth group some guardrails, if you will, some ways to begin to hang on to some things that they can understand. I'll give you a very concrete example. One of the things my daughter is very fond of are sweets and especially any kind of baked goods. And so if they go on a mission trip, if they go and do an activity somewhere in town, she knows to ask for a buddy to help her make good choices because she knows she will not trust herself to make those choices on her own. What might that look like in terms of a class or any kind of program setting within a congregation? How might people work alongside each other at a service project, for example? How might people participate in worship alongside each other in leading worship or in participating in different ways? I think it is that alongside that journey with what is already in existence, rather than trying to convince people that there might be something interesting or important that they need to do that they've not experienced before. That may be harder to get people to participate in, and it sounds like it has been for you.
Yeah. I think, and looks like there's just one other question, and actually this is one that's related to some of my interests as well. Are you seeing any really good examples nationally of how university training is preparing future professionals to address spirituality in their work with people with disabilities? What might it look like to do this beyond just sharing written guidelines?
So I'm looking at that primarily through the lens of spirituality. I actually last semester had the opportunity to co-teach a class on faith communities and spirituality at Candler at Emory University. That's really been a delightful experience, and one that in some ways I start the class by actually bemoaning the fact that we need the class. It is structured so that each of the different disciplinary areas within a theological education are addressed. What I long for is that to already be embedded in those classes in much the way I was talking about within a congregational setting. We have some models that are taking place in other universities and other seminaries, divinity schools. As I'm sitting here, I can probably pull them up if I had my laptop in front of me, and I don't. The hopeful places that we're seeing some really interesting things come from, some of the work that Bill Gavent is doing with Baylor, I think is really exciting. I'd be curious, Eric, if you've got some things that you're aware of from around the country as well. The other area are the kinds of workshops and activities that groups like the Association for Clinical Pastoral Education and the Association of Professional Chaplains have been developing to provide a more substantive approach to this rather than simply a reactive or an individualistic approach to it. There are some really important core themes of caring for and with people with developmental disabilities that are embedded within those pieces. We've got a couple of those posted on the ACPE YouTube site, so you're welcome to take a visit there. That's a public site, and anyone can go and look at those. Some very good ideas. And Bill's recent book on disability and spirituality is an incredible resource as well that I think folks should really take a look at too. Eric, what about you? Are there other spots?
The ones that I know about are the ones that I've been directly involved in. One was at JFK Partners, the UCEDD in Colorado when I was still there. We embedded students from Iliff Theological Seminary as LEND trainees. That is still going on. I was previously the director, but when I moved to Wyoming, I kind of gave that to another faculty member. It's still going, and I don't know how they're going to maintain that, if they plan to or not. So that's the one that I know most intimately. We're trying to start something similar in Wyoming through our UCEDD, but that's still very nascent at this point. But Bill or Eric Carter, if you know of anything else, please chime in.
Eric, I noticed there was another question from Amanda.
Oh, yep. Thank you. Let's see. Is it appropriate for a church to create a program that specifically serves the needs of this population, or is that singling out?
Um, I think anytime we segregate, we're probably doing a disservice. I think there was a time where those sorts of programs may have had a place, and I know in some congregations, it's been very hard for them to ever make any kind of a move, often because people have very strong emotional ties to establishing them. But I am not sure it makes sense in terms of the overall life and health of a faith community to single out a group and to have them separate from others. Um, I would love to see us develop some research, particularly around that. I don't know of any at this stage, but I do think that that would be a really important area to pay attention to.
Can I ask a follow-up to that, Trace? When you say
Sure.
singling out, I guess in my mind, I'm envisioning you meaning like there's a very specific, dedicated and separate program for people with disabilities. But I'm comparing that with other programs. I know, like there's a church that I'm aware of that does. They call it a ball. It's sort of a dance. It's a special kind of a prom, but it's designed specifically for the whole community, the whole city that they serve, for people with disabilities, so that they can have a special night, and it engages the whole community. So they try to make it as sort of inclusive with a very unique focus. So I just wondered if, when you said singled out, did you have one kind of a incarnation in mind?
Yeah, so historically, some of the first classes that were established, or spiritual care kind of settings within congregations, actually created a separate program where folks went to their room. They stayed in their room. And in some ways, that to me very much models what happened in public education. It's sort of how we knew to do this. There may be, for some families and even for some individuals, that may be very important for them. So Bill is reminding me that it is important to start with the individual. So what is their choice and what is their preference? On the other hand, when that is kind-heartedly created by neurotypical peers without asking, that's when you run into problems. I'm aware of the prom model as well. I think of Special Olympics as another kind of model along the same way. My daughter actually went to the prom a couple of weeks ago. It's sponsored by the Tebow Foundation. And she had a great time. She loves it. It's something that she loves to do every year. And so I wouldn't want to say that those things are not necessarily important or valuable. And yet at the same time, I also wouldn't want them to get in the way of an inclusive opportunity as well.
Mm-hmm. Yeah, and then Amanda follows up. She said, I was thinking something like a sensory-friendly worship service each week or month.
Yeah, so I think that there are ways of actually both modifying worship, but also creating worship spaces that allow people to fully participate. An even more dramatic example of that, I was just at the Alliance Theater here in Atlanta. They've just gone through a new renovation, and they accidentally created a space that makes the theater more sensorily available to people that might have sensitivities to things and noises and lights that might happen within a performance. They created it because they do a lot of development of shows that go to New York to Broadway. They have this space now that is glassed in, and the volume can be controlled and the lighting can be controlled. And they didn't even realize what they were doing is creating a space where a number of guests could now bring their children who have autism. It was an accidental inclusion movement. I would love to see more intentional inclusion movements along those lines.
And then Bill followed up. He said there's still lots of special education ministry where kids do not mix much with other kids and can become a ghetto in the church.
Yeah, that's the piece that makes me nervous, is when folks. I'm aware of a church here in town in Atlanta that they just want to do special things for those people, and there's a lot of code in what I just said that tells me I really want to spend some time with them thinking about how can people who have different abilities or different challenges be more fully included in the life and breadth of what their congregation is all about.
Yeah. And Bill adds again, there's a variety of worship models, rejoicing spirits, messy church, and others that attract people with a variety of needs, but also others because it is engaging and fun. Sometimes parents feel that those are the safe spaces for them to be in, often with past experiences of being asked to leave.
Yeah.
And then they're coming in now. Let's see. Mary Jo said, in my congregation, we developed the inclusion ministry program to manage local high school students coming in to do work study in our church. We have developed a mentor program with these students and the nearby senior living community. Great.
Those are the stories that we need more of too. Let me just, as a way of kind of wrapping up, we need to find a way to gather those stories. Eric's done some good work in this. Bill's done some good work in this. What we need is to find ways to make those more accessible across some of the theological divides that have made some of these conversations so hard as well. So how do we begin to tell the good tales so that people can really bring these kinds of resources into their own context?
Yeah, absolutely. And we're approaching the end, so I do want to be respectful of everybody's time. And just as a last announcement, we've got our upcoming webinar on February 20th, 1 p.m. Central. So do the math for your time zone. The title is Intersection of Health and Spirituality, Current Research Trends and Implications for People with Disabilities and Their Families. And then March 20th, same time, Inclusion of Students with Disabilities in Catholic Schools, Finding Ways to Welcome Students from the Sidelines. And site there, faithanddisability.org, is where you can register for those. And then the Summer Institute on Theology and Disability will be held in Holland, Michigan from May 20th to 23rd. And you can get more information at the website, again, faithanddisability.org. It's under our project section under the Summer Institute tab. So with that, thank you everybody for joining, and thank you again, Trace, for a great conversation and discussion about this very important topic.
Thank you all. I appreciate the time. Great to have everybody's questions.
Thanks, everyone.